আচ্ছা, see, non-fermenting bacilli and hospital-acquired infection. I'll try to cover up HAI as much as possible, but পুরোটা cover করতে পারবো না in a class. So we'll just stick on to the diagnosis and what is the thing and how it can be prevented, the most important things. Now coming to the non-fermenters, we'll discuss only the three relevant bacteria. Non-fermenters এর মধ্যে যেগুলো pertinent bacteria which causes HAI are Pseudomonas, Acinetobacter and Burkholderia. ঠিক আছে, এই তিনটে মেন অর্গানিজম দ্যাট কজেস ইনফেকশনস ইন হিউম্যান বিং পার্টেনিং টু দ্য HAI। কারণ হসপিটাল অ্যাকোয়ার্ড ইনফেকশন অনেক ব্যাকটেরিয়া করে, ঠিক আছে। এসকেপ প্যাথোজেনের নাম শুনেছো? হোয়াট আর এসকেপ প্যাথোজেন্স? এনিওয়ান হ্যাজ হার্ড অফ ইট? এসকেপ, so we have a slide of escape pathogen also. So non-fermenting মানে কি? They do not ferment the sugars, but they utilize the sugars oxidatively. ঠিক আছে, most of the bacteria here are aerobic bacilli, ঠিক আছে। obligate aerobic কিছু আছে। obligate মানে কি? what is facultative and what is obligate? obligate মানে they cannot survive without that thing, আর facultative মানে they can survive without that thing, correct. So the most important bacteria in the NFGNB মানে non-fermenting Gram-negative bacilli are Pseudomonas, Burkholderia, Acinetobacter and Stewardship and Schwannella. Stewardship টা খুব একটা বেশি নেই বইতে, আর খুব একটা প্রশ্ন আসে না Stewardship নিয়ে। তো so we'll first start off with the Pseudomonas. Pseudomonas হচ্ছে one of the most notorious bacteria that we face each and every day from various samples. Pseudomonas can cause UTI, Pseudomonas can cause respiratory tract infection, Pseudomonas can cause burn infection, Pseudomonas can cause soft tissue infection. So many things Pseudomonas can cause. And why Pseudomonas is important is Pseudomonas is they may not have a carbapenemase at all. এরকমও হয় যে সিউডোমোনাসের মধ্যে কার্বাপেনেমেজ হয়তো তোমার এনজাইমটা নেই, the drug resistant the carbapenemase is not there, but Pseudomonas acquired so much of drug resistant via multi drug resistant efflux pumps. efflux pump পড়েছো তো? drug resistance of a bacteria হয়নি পড়া? ছিল তো প্রথমে। তাহলে ড্রাগ রেজিস্ট্যান্স কিভাবে অ্যাকোয়ার্ড হয় ব্যাকটেরিয়ার মধ্যে? আইদার দে হ্যাভ দ্য জিন অর দে টেক আপ দ্য জিন। তো ইফ দে হ্যাভ দ্য জিন দে উইল প্রডিউস দ্যাট স্পেসিফিক the enzymes, a specific set of mechanisms that will drive out the drug. আরেকটা মেকানিজম হয় যেটা হচ্ছে ইফ্লাক্স পাম্প। ইফ্লাক্স পাম্প মানে there are certain structures in the cell wall or the cell membrane of the bacteria, সেখানে কি হচ্ছে না, those structures এর মধ্যে থেকে if at all the antibiotic goes inside the bacteria সেটা আবার বাইরে পাঠিয়ে দেয়। So this is an intelligent mechanism that drives the antibiotic out of the cell, that is called efflux pump. So efflux pumps are moderated by many chemicals. Few efflux pumps are moderated by metallic ions like zinc. আর অনেক কিছু আছে। So if you read about efflux pumps you'll get to know that. Oxidase positive, that is the most important thing of Pseudomonas. If you get a Pseudomonas in a plate, you will get to know in 5 seconds that it's a Pseudomonas. কি করে বুঝবে? The first and foremost is they will be having pigments. This is one bacteria that gives beautiful pigments. অনেক রকম পিগমেন্ট দেয়। The most commonest pigment is the first one, that is pyocyanin and pyoverdin. এই দুটো পিগমেন্ট যারা যারা মাইক্রোবায়োলজিতে করেছে in the first year or first 6 months they will see pyocyanin and pyoverdin. Okay, pyocyanin কি কালার দেখো? ব্লু গ্রিন, and pyoverdin is greenish yellow. Okay, so if you have a Pseudomonas in a nutrient agar plate, you will definitely get to know the pigment. Nutrient agar plate you can appreciate the physical characteristics of a bacteria, what they give. আর দুটো পিগমেন্ট হচ্ছে পায়োরুবিন, রুবিন মানে হচ্ছে রেড, অ্যান্ড আরেকটা হচ্ছে পায়োমেলানিন। মেলানিনটা একটু ব্রাউনিশ ব্ল্যাক কালার। ইট ইজ নট সো কমন, ইট ইজ এ কাইন্ড অফ রেয়ার পিগমেন্ট দ্যাট দে প্রডিউস। এখানে সমস্ত পিগমেন্টের ছবিগুলো আছে, ইউ ক্যান হ্যাভ আ লুক। and there is one agar that is utilized, that is given for to promote more pigment production. So acha, first we will see the virulence factor. Virulence factor মানে হচ্ছে the mechanisms the bacteria has to adapt to the human system, to give rise to the disease, okay, or to evade the immune response. So those things are the virulence factors. Virulence factor কি আছে ব্যাকটেরিয়ার মধ্যে? First হচ্ছে colonization. Colonization মানে কি? What is the difference between colonization and infection? Colonization মানে the bacteria will be present somewhere inside your body without doing any harm yet, okay. So they will be just loitering around in that part. So they will first colonize. First একটা হবে, 100টা হবে, 1000টা হবে, 1 লাখটা হবে. So that is a colonization. They have not yet started to invade your body. Then what will happen is colonization করতে করতে they will form a biofilm. Biofilm মানে হচ্ছে একটা aggregate of a bacteria. A number of bacteria stuck together with a self secreted matrix. So that is called a biofilm. So once a bacteria forms a biofilm, they communicate each other with certain proteins called quorum sensing. So the bacteria will secrete an extra polysaccharide matrix that is called biofilm. সেগুলোর মধ্যে ব্যাকটেরিয়াটা আরো ভালো করে জায়গাটার মধ্যে বিস্তার করে থাকলো, okay. And once a biofilm is formed, it is very difficult to penetrate a biofilm. The antibiotics do not penetrate a biofilm. যতই অ্যান্টিবায়োটিক দাও না কেন, it will be there because ব্যাকটেরিয়াটা শুধু নেই, ব্যাকটেরিয়াটা একটা ম্যাট্রিক্সের মধ্যে আছে. Okay, so Pseudomonas is famous for producing biofilm. Okay, first colonization পরে adhesion. So they will have certain pilus or fimbri for adhesion, because if the bacteria doesn't adhere to the surface, they will be washed off. So they cannot produce an infection. So they have to be adhered to the surface. কিছু toxins আছে, তার মধ্যে কিছু non diffusible toxin আছে like exotoxin, SUTY, and certain diffusible toxin like phospholipases, proteases, etc. Okay, so these are the toxins that the bacteria has, and one more important toxin is exotoxin A. That is the most potent toxin of Pseudomonas aeruginosa. Exotoxin A কি করে? They inhibit the protein synthesis, so they definitely help in infecting or penetrating through the cells because they inhibit the protein synthesis. Okay, এটা তো বললাম. আচ্ছা, alginate coat কি জিনিস? ওই similar thing like a biofilm, the mucoid strains, কিছু কিছু Pseudomonas যেগুলো mucoid strain আছে, so they will secrete a slime layer. So ultimately that slime layer will give rise to a biofilm. So again that biofilm helps in the adhesion, as I told, and it's impermeable to antibiotics. Few chemicals like silver nanoparticles, they can have a property of disrupting biofilms, okay. So silver nanoparticles does have a property of disrupting certain biofilms up to a dose dependent concentration. আচ্ছা, ক্যাপসুল থাকে কিছু সিউডোমোনাসের, again capsule is again resistant to antibiotics, and multi-drug resistance so আছেই, as I told. Clinical manifestation, I have told that they causes n number of infections starting from all the HAIs. HAI কি কি আছে? Hospital acquired infection, catheter associated UTI, ventilator associated pneumonia, that is VAP. Then you have CLABSI is what? Central line associated bloodstream infection. Another one is there, that is SSI, surgical site infection. So Pseudomonas aeruginosa is famous for doing all the 4 HAIs, okay. এছাড়া আর কি করে? They can do infective endocarditis, they can do swimmer's ear, কানের ইনফেকশন করতে পারে, ওটাইটিস ম্যালিগন্যান্ট ওটাইটিস এক্সটার্না করতে পারে, আই ইনফেকশন করতে পারে, সাংঘাই ফিভার করতে পারে, and most important is they do produce burn infection very commonly. The burn patients first 48 hours is very crucial for hemodynamic stability. First 48 hours কিন্তু burn patient, they do not die of infection. What they'll die of? They'll die of hypovolemia. If you do not resuscitate the patient with correct volume of IV fluids, they'll die of hypovolemia. The infection will set off after 72 hours. তো সেখানে কমনেস্ট হচ্ছে Staphylococcus aureus and Pseudomonas aeruginosa. Any kind of infection that is superficial, the Pseudomonas aeruginosa may produce a greenish color. So by seeing the color of the pus, or by seeing the color of the, the crumbs or the, the superficial part of the tissue, you can guess that if greenish color is present, Pseudomonas aeruginosa can be a contaminating or infecting organism. আচ্ছা, এছাড়াও সেলুলাইটিস করে, গ্রিন নেল সিনড্রোম, প্যারানোইকিয়া করতে পারে। ল্যাবরেটরি ডায়াগনোসিসের মধ্যে ফার্স্ট থিং দ্যাট উই ডু ইজ উই ডু আ গ্রাম স্টেন. What will you find? You do a gram-negative bacilli, plain and simple. Then whenever we see this kind of color in nutrient agar plate, we suspect that it's a Pseudomonas. Pseudomonas এর দুটো জিনিস very important, একটা হচ্ছে color আর একটা হচ্ছে smell. It gives a very sweet kind of fruity odor. I don't know why they call it fruity. I don't find it fruity, but I find it sweet. Okay. If you smell a Pseudomonas, you don't have to smell a Pseudomonas, you will automatically get the odor when you open a plate. You will see, alcohol like fruity odor. And je media tar kotha bolchilam, that media enhances the color production of the organism, is called King's media. Okay. Generally we don't use it. We see the color in nutrient agar only. Acha, the next test, the first test that you do in Pseudomonas is a oxidase test. It is a rapid test. You have an oxidase disc. Okay, you take one colony, you put a control like a non-oxidase producing organism like E. coli, and then you inoculate this organism in the oxidase disc. You find the color is turned to violet, purple color hoye jacche, dekhecho. So this is oxidase positive. So Pseudomonas is oxidase positive organism. Now rest of the thing, the McConkey agar er moddhe non-lactose fermented colony, as you have all said. Blood agar er moddhe they give a beta lysis. তিন রকম লাইসিস হয়, আলফা বিটা গামা. they'll give a beta lysis in blood agar. নিউট্রিয়েন্ট আগারের মধ্যে আমি বললাম ব্লু গ্রিন ডিফিউজিবল পিগমেন্ট থাকবে আর একটা মেটালিক শাইন থাকে. দ্যাট ইজ অলসো আ ক্যারেক্টারিস্টিক অফ Pseudomonas. they will have a metallic shine to it. Biochemical in mode, most of the biochemicals are negative except oxidase and citrate. So they will be utilizing citrate, a monocarbon citrate they will be utilizing. And oxidative fermentative jodi koro, then you will see that the bacteria is oxidative. Okay. So this is how it looks. It is very thin GNB, little elongated, but you cannot comment on the organism by seeing the gram stain. Only you can tell that it's a gram-negative bacilli. With experience we know which is a Pseudomonas, which is Acinetobacter by looking at the gram stain, but usually it is not commented on that. Again, the bacteria can be typed. Typed মানে যতগুলো bio pattern আছে, যতগুলো genome species আছে, সেইগুলোতে you can type the organism according to bacteriocin typing, according to antibiogram typing. It is very easy and we do it very frequently to determine any outbreaks have occurred or not. একটা ওয়ার্ড থেকে যদি 5টা Pseudomonas আসলো এক সপ্তাহের মধ্যে, and if they have a bio pattern which are different, we cannot call it an outbreak, because outbreak means that one organism has to spread the infection to the other patient, which is abnormal to the time frame and to the place. So if you have 5 different Pseudomonas with a 5 different bio patterns and infecting 5 different patients, you cannot call it an outbreak. It has to be from one patient spreading to another patient. Okay. Acha, molecular method, you have a pulse filled gel electrophoresis which can be used for the molecular typing. Antibiotic choice depends on the antibiogram of the organism. So you don't have a single drug which is applicable for all, but nowadays we have a guideline called IDSA guideline, Infectious Disease Society guidelines we have. So that tells us that whenever we are finding a DTRP Pseudomonas, DTRP means difficult to treat. Okay, so that is a MDR organism, multi-drug resistant Pseudomonas, which is resistant to most of the antibiotics including carbapenems. Then we have to give something called ceftazidime avibactam. So DTRP or XDR organism Pseudomonas can be treated with ceftazidime avibactam or cefiderocol. There are few drugs which can be given. Mostly Pseudomonas is sensitive or not sensitive, is intermediate to colistin. So we don't have a sensitive zone of colistin. Colistin is শুধু resistant হয় and intermediate high. We don't have a sensitive zone. So you can give penicillin if it is a pan susceptible. You can give carbapenems like meropenem, imipenem. You can give BL-BLI combinations like beta-lactam and beta-lactam inhibitor combination like piperacillin tazobactam, like cefoperazone sulbactam. You can give those things if the bacteria is sensitive to that. And then you have colistin and polymyxin B. Okay, so next you have Burkholderia. Burkholderia is very dangerous. Okay, this is an agent of bioterrorism. You know what is a bioterrorism? Biological warfare. ঘরে একটা চিঠি এলো, চিঠি খুলে দেখলে কি anthrax's spore. That's how it spreads. Spore can be resistant to the environmental conditions, and Bacillus anthracis can spread through spores. That's how it was spread once in a bioterrorism warfare. Okay, so this thing Burkholderia also can cause a biological warfare. Burkholderia কোন স্পিসিসটা? Burkholderia pseudomolai. They have a few species, but 3 of them are clinically important. One is Pseudomonas, which causes something called melioidosis. One is called Burkholderia cepacia, that causes cepacia syndrome. And one is called Burkholderia melai. Okay. So, Burkholderia Pseudomonas causes melioidosis, as I told. They are oxidase positive, just like Pseudomonas, and they have, the habitat is that they exist in soil and water. So, they have an environmental habitat. The mode of transmission is inoculation, that can be inoculated on your skin if you have an injury. Then you have inhalation and ingestion. Okay, so these are the 3 routes that they spread. And what is exactly melioidosis? Okay, that is called Vietnam time bomb disease. কেন বলা হয়? Vietnam time bomb disease. Time bomb disease মানে বুঝতে পারছো, they have a longer incubation period. So the moment you have the infection, you don't get to know the next day. So it takes time to develop the infection, and once it develops, you will have a definite, fulminant pulmonary infection which mimics tuberculosis. So that's important. So that mimics tuberculosis, and then you have another thing which is very important, is skin ulceration and lymphadenopathy. এই দুটো জিনিসও তার সাথে থাকে. So you have a respiratory infection, you have lymph node that is swollen, and then you have skin ulceration. Okay. কোথায় কোথায় পাওয়া গেছে? You have these things in Tamil Nadu, Maharashtra, Orissa, West Bengal, and Pondicherry and Kerala. Last, I think 2 years back, I had a case of Burkholderia pseudomolai that was isolated from somewhere in Durgapur area. Okay, again that was given by, that was not molecular confirmed, that was given by this automated AST, automated IDAST methods. So generally we rely on automated IDAST because we don't have molecular setup at every lab to give a ID. So similarly, see, this is a gram-negative bacilli again, but there is one characteristic which is very unique, that is they have a safety pin like appearance. Okay, safety pin আর কোথায় পড়েছে? Correct. So you see this thing, they have a bipolar stained, দুটো পোল বেশি করে স্টেন নিয়েছে, মধ্যখানটা একটু ফাঁকা. So that gives the appearance of a safety pin. Okay, if you stain with methylene blue, in fact gram stain বোঝা যায়. Pseudomolai again is an obligate aerobe, nutrient agar, blood agar, and McConkey agar is enough to grow them. And they have a colony which is rough and corrugated, similar to Pseudomonas stutzeri. And selective medium যদি বলা হয়, then we have Ashdown's medium as a selective medium. So this is how they look, corrugated. This is the Ashdown medium, and they look like this. Okay. Okay. So the treatment part, as because it is a very fulminant infection, we have 2 phases of, ঠিক টিবি যেমন করে ট্রিটমেন্ট হয় এটারও তাই. You see, TB again they have a initial intensive phase and they have a continuation phase. Okay. Similarly, we have an intensive phase of 2 weeks with ceftazidime or carbapenem, like meropenem, imipenem, and then we have a maintenance phase of 12 weeks. So total 14 weeks of treatment is required for a patient if the patient is affected with a pseudomolai. 12 weeks টা কি দিয়ে দেবে না, oral cotrimoxazole. So, that is what it is recommended for melioidosis. Again we have Burkholderia malai, which is a second group. This is mostly animal pathogen, okay, that affects horses. Horses er moddhe ki kore, they give rise to something known as glander's disease and farcy. So, this is again some nasal ulceration and nasal discharge and skin ulceration kind of a thing. But in human infection, they are characterized by skin nodules, some pneumonia, and ulceration can also occur, similarly to the Pseudomonas. Achha. Next is Burkholderia cepacia. So, we get a Burkholderia cepacia a lot from the hospitals. Okay. The reason is this organism, they love water. They love, they love to harbor inside the waterborne, like the water based things that we use in the wards and ICUs. What is the most common thing that we used, which is water based? এই যাত্রা নিয়ে এত লেখালেখি চলছে কি সেটা IV fluids. So, if you have a contaminated IV fluids, if you open the IV fluid and keep it for a long time and then give to the patient, so if the IV fluid is contaminated, if a syringe is contaminated with some water for a long time, then that can develop to harbor this kind of organism like Burkholderia cepacia. So, we do not have a cepacia directly, we have a cepacia complex that is reported by the automatic ID. So, they are existing in the moist environments, detergents and IV fluids. They give rise to cepacia syndrome. Kader hoy mostly eta pulmonary infection. যে পেশেন্টগুলোর সিস্টিক ফাইব্রোসিস আছে কিংবা লাংসের কোনো রকম পার্মানেন্ট ডিসেবিলিটি আছে, স্ট্রাকচারাল ডিফর্মিটি, সেখানে এগুলো ম্যাক্সিমাম দেখা যায়, বিকজ দ্য লাং টয়লেটিং ইজ ব্যাড ইন দোজ কাইন্ড অফ পেশেন্টস, দ্য সিলিয়ারি মুভমেন্ট, the cuff reflex. So, all these things contribute to the factor that give rise to the infection. The important thing is this organism is resistant to multiple antibiotics. So, it is mostly a MDR, so multi-drug resistant organism. এছাড়াও they have caused pneumonia and wound infections. আচ্ছা, they are they grow in normal Meconic agar and bladder agar, so no special media is required mostly. Treatment again is based on the antibiotic sensitivity pattern that you get from each of the organism, but they are mostly sensitive to cotrimoxazole. So, that is one way of treating them. তাছাড়াও meropenem and doxycycline, they have a equal good sensitivity pattern. Next, you have Acinetobacter, the commonest organism isolated from which infection? Ventilator associated pneumonia, VAP. Acinetobacter is the most common organism to cause VAP. Acinetobacter অনেক স্পিসিস আছে, তার মধ্যে মোস্ট রেলিভেন্ট স্পিসিস হচ্ছে Baumannii. Acinetobacter species, Acinetobacter calcoaceticus and Acinetobacter lofi. These are the three most commonest species. Baumannii important because that is the most important pathogen. Calcoaceticus and lofi is not so clinically relevant, they are mostly contaminants, okay, but in few cases they can cause some infection also. So, what is that thing that Acinetobacter does? It again colonizes the patient like Pseudomonas. And as because it is a soil saprophyte, they can be harboring on your skin also. So, isolating Acinetobacter from a skin of a patient does not necessarily mean that the patient is infected. Okay, the patient may be colonizing the Acinetobacter, and once the immunity is down, or you put a line which takes the Acinetobacter inside the bloodstream, that can cause an infection. Okay, so coming to the MDR, mostly the Acinetobacters are multi-drug resistant. Nowadays, I see Acinetobacters are pan-drug resistant also. So, they are resistant to colistin also. So, in those cases which are XDR and which are mostly producing the carbapenemase producers, so those are not susceptible to any of the beta-lactam antibiotics. So, what you have to do is you have to give them high dose of sulbactam. Okay. So, that is what is recommended by IDSA. So, you give a cell wall acting agent and then you give a high dose sulbactam. So, that is recommended. Again, they can form a biofilm. They have a lipopolysaccharide which can be produced by the organism, and they have certain things called siderophores which again give rise to evading the antibiotics. আচ্ছা কি কি করে বললাম, the first most common is VAP, then you have a CRBSI or a CLABSI. Catheter associated urinary tract infection করে but not so common. Wound infection, blood infection, bloodstream infection, primary and secondary BSI, they can give rise to. Acha, when you plate the organism in the blood agar, they are non-beta lytic, so they don't have lysis, they are just and then in McConkey agar, they are non-lactose fermenting pale colonies. If you have a trained eye, in the first seeing the colony in a McConkey agar, you will get to know it is Acinetobacter. The colonies are very beautiful. It is absolutely round, and they will be. It is very common to find Acinetobacter, and you will definitely recognize it if you see this thing twice or thrice, maybe. Okay, so this is how it looks in McConkey agar. See the colonies are মানে পুরো জিনিসটা গোল with a discrete border. It is not flat, it is convex, and it is round, and it is non-lactose fermenting. And in the blood agar, you don't get to see a hemolysis, so they are non-lytic colonies. Okay, so there's a gram-negative coccobacilli. Whenever you do a gram stain, you see something like this. Okay, so this is not a bipolar staining. What you see here is coccobacilli. জিনিসটা bacilli, but they look like a coccus. Okay, মধ্যখানে দেখো জিনিসটা একটু গোল ককায়ের মতো বাট একটু লম্বাটে। ওকে, so this is a little different from the rest of the GNBs. When you see Acinetobacter in a gram stain, you will definitely recognize it if you have seen it before. So this is, we call it gram-negative coccobacilli, GNCB. Whenever you report a GNCB in a ET suction or ET secretion or a bowel fluid, definitely the consultant will know that this is, this can turn out to be Acinetobacter. So that's how we indicate the thing through gram stain. So this can be gram variable. Gram variable মানে কি? What is gram variable? Last bench. What is gram variable? Nobody knows. বলো কি বলছো? Yes. So gram variable means it has a variability in taking up the stain. So they are gram negative, but sometimes they may take like gram positive also. Okay. So gram variability কোথায় পাওয়া যায় বলো দেখি? When do you have a gram variability? Klebsiella will never be gram positive. I mean never look like gram positive. Lipopolysaccharide থাকলে হতে পারে, I agree. Whenever a colony is old means 3-4 দিন পুরনো হয়ে গেছে প্লেটটা, then you do a gram stain. Then you will see the organism, if it is gram positive or gram negative, they may show a gram variability, because whenever a colony is old, the cell wall integrity is lost. Not lost, partially lost. So the retaining power of the methyl, the crystal violet. So gram variability can be seen in a colony which is old, and when you do a gram stain, and certain organisms like Acinetobacter also. Okay, so this is a non-fermenter. This produces no gas, and in TSI you have a K by K pattern. K by K pattern ki? What is a K by K pattern? আমি ইচ্ছা করে ওখানে লিখিনি, so that I can ask you. Red shirt, last bench. K by K pattern কাকে বলে? In TSI, how do you interpret the TSI? TSI এর full form টা বলো আগে. What is a TSI? T for triple, S for sugar, I for iron. Now you tell me, what are the 3 sugars? Not read microbiology. This is a basic question. If you don't understand what is a TSI, you will never get to remember how does a Acinetobacter give the reaction in a TSI. So you have to read. K by K means alkaline slant by alkaline butt. Okay. A by K means acidic slant by acidic butt. A by A means acidic slant by acidic butt. Okay. So in TSI there are 2 more properties that you see. One is a H2S production, and another one is a, okay, so it is a negative for indole and urease. Now this is how you differentiate between a colonizer, I mean non pathogenic strain and a pathogenic Baumannii. That is, citrate is utilized by the Acinetobacter baumannii, so you'll have a citrate positive at 42 degrees Celsius. If you keep the plate after inoculating the organism, if you keep the plate at 42, the baumannii will grow and Lofi will not grow. So that's how you can differentiate. Then again, oxidative fermentative test. Bowmani will show oxidative and Lofi will show a saccharolytic pattern. But important thing is citrate and 42 degrees Celsius growth. So those are the two things that I used to do in my PG days because we didn't have automated system by that time. Now, yes, treatment as I told, treatment bolte kono rokom particular drug bole dilei seta diye dilei hoye jabe ta noy. It definitely needs the antibiogram of the organism and then you can treat. But mostly they are sensitive to colistin and they are sensitive to ceftazidime avibactam and they are sensitive to carbapenems also. But it is very difficult to predict which one will be until unless you do a antibiotic sensitivity testing. So AST is important and you have to do in each of the bacteria that you get in the hospital. Otherwise, you will not get to treat the patient because they have so many kind of this carbapenem producing genes. They have a MBL, that is a metallo-beta-lactamase. They have called OXA23. OXA23 is only present in Acinetobacter. The rest of the Enterobacteriaceae you have seen OXA48. But Acinetobacter will have OXA23. And the most important thing is, most of the labs, they don't have a OXA23 testing. The panels that we have of the carbapenemase enzyme, we have a IMP, we have a VIM, we have a KPC, we have a NDM. NDM mane ki? New Delhi metallo-beta-lactamase. So it's a metallo-beta-lactamase. And we have a OXA. So that OXA is 48, that is not 23. So if you put a Acinetobacter for a testing, that OXA48 will be negative and you will think there is no carbapenemase, but that is false. Acinetobacter has something called OXA23. So OXA23 they have in few panels, but most of the panels they don't have OXA23. Okay, now coming to the important topic again, that is a healthcare associated infection, HAI. Okay, so this is huge and this is the most important topic of this era because we have n number of hospitals and we have n number of patients. But the thing is that healthcare associated infection is, we are the key responsibility person that give rise. The doctors, the nursing staff, the ancillary staff. 18 responsible, mostly. So the key persons or the stakeholders of this HAI are us. If we don't have a perfect infection control practices, then the hospital infection goes for a toss. Ki korte hai bole dicche. So first the 4 diseases that you have told, VAP, CAUTI, CLABSI and SSI. Okay. Now starting off with the definition. See, I'll tell you a scenario. The patient has come with fever and cough to a hospital and they put the patient on antibiotic therapy and the patient required a catheter. Okay. So the patient has come in with a fever and the next day they have put a catheter in the patient, Foley's catheter. Now on day 2 they have put the Foley's catheter. On day 3 they send a culture from the urine, from the catheter. Okay. That culture grows a Klebsiella. Now can we call it a hospital acquired infection? Can we call it? আজকে ক্যাথেটার পড়েছে, কালকে কালচার গেছে, মানে আগামীকাল, সেটা কি হসপিটাল অ্যাকোয়ার্ড হলো না? হসপিটালেই তো ক্যাথেটার পড়েছে, বাইরে থোড়ি পড়েছে, কেন হবে না? হ্যাঁ? Okay, so this is the definition. Any line or any devices which is giving rise to a HAI must be present inside the patient body for 48 hours minimum. So that symptom should appear after 48 hours. Now next thing is যেগুলো আমরা মিস করে যাই সেটা হচ্ছে NSI. NSI is needle stick injury and এর সাথে সাথে আছে exposure to blood and body fluids, যেটা এখানে লেখা নেই. Okay, so if you have these two kind of things then also you can have an infection. সেগুলো আমরা পরে আসবো, বাট আগে এগুলো কভার করি. So yes, WHO data says 7% of the patients in developed and 10% of the patients in developing countries have acquired at least one HAI. So you can see how much a problem the world is suffering from it. Mortality is 10% and is definitely causes a huge economic burden to the hospital. See, the patient has come in with a CVA that does not require any antibiotics. The patient goes into a ventilator. That patient after 72 hours develops a VAP with Acinetobacter, which is PDR, and you give the patient high dose of this thing, antibiotics, and then you give colistin, which was not necessary because the patient has come in with a CVA, cerebrovascular accident. Okay. So, in those cases you are giving an antibiotic because you have to tackle the VAP. Definitely the patient's cost increases. যে জিনিসটা কি আমরা পেশেন্টটাকে 7 দিন বাড়ি পাঠাতে পারতাম সেটা 1 মাস লেগে যাবে সারাতে। So it is difficult, okay. And most of the organisms are MDRs because সেগুলো অনেক এনভায়রনমেন্ট থেকে আসছে, অন্য পেশেন্ট থেকে আসছে, so definitely they have traveled many vectors or many people in between. So source of the infection, এই যে বলছি হসপিটাল অ্যাকোয়ার্ড ইনফেকশনটা হচ্ছে কি করে, কি সোর্স থেকে হচ্ছে? ফার্স্ট হচ্ছে দুটো ইম্পর্টেন্ট সোর্স, একটা হচ্ছে এন্ডোজেনাস, দ্যাট ইজ ফ্রম আওয়ার ওন বডি, আর একটা হচ্ছে এক্সোজেনাস। সি আমার মধ্যে যে ব্যাকটেরিয়াটা আছে সেটাকে কন্ট্রোল করতে আমি পারবো না, দ্যাট ইজ নট ডুয়েবল, বাট এক্সোজেনাস কন্ট্রোলটা করতে পারবো। এক্সোজেনাস কী কী আছে দেখো, হসপিটাল এনভায়রনমেন্ট, বিভিন্ন সারফেসেস, all the surfaces, all the non-living objects can act as a fomite. Fomite মানে কি? Potential, no? It is not a potential of doing something. It is an object that acts as a carrier of the organism. Okay? So this thing right here in my hand can act as a fomite. কি করে? Patient কে আমি ধরলাম, examine করলাম. I change the catheter. I do a endotracheal suctioning. I don't do a hand wash or a hand hygiene and I touch this remote, and then again I touch the next patient. So this remote is contaminated by Acinetobacter, and somebody who is touching this remote again will have again Acinetobacter on their hands. So this is a transient flora. Two types of floras are there in the skin: resident flora, transient flora. Resident flora means that flora that will be there with your life. ওটা তুমি ভাগাতে পারবে না, that will be there on the skin and the subcutaneous tissue. Transient flora is that will come and go. That will come, you will wash your hands, that will go. Again that will come, you wash your hands, go. So this is a transmission by transient flora. So patients, patient to patient transfer. COVID, একটা patient এসছে, একটা ওয়ার্ডের মধ্যে এসে কাছাকাছি শুরু করলো, পাশের পেশেন্টটা কোভিড হয়ে গেল। So that is how it is transmitted. Inanimate objects, air, water, food in the hospital. Salmonella, টাইফয়েড মেরি কে ছিল বলো? Yes, কি করেছিল? So she was famous for spreading salmonella. Okay, so food থেকে অনেক কিছু ছড়ায়। Okay, now MRSA কোথায় থাকে? What is MRSA? Methicillin resistant, methicillin resistant staph aureus. Methylene blue is a dye. Okay, so this is a escape pathogen. Okay, escape pathogen is very important. E for Enterococcus faecium, not fecalis, faecium. Then you have S for Staphylococcus aureus. It can be MRSA, it can be methicillin sensitive also. Then you have K for Klebsiella pneumoniae, and then you have A for Acinetobacter baumannii, P for Pseudomonas aeruginosa, and E for Enterobacter species. Okay, so these are the organisms that are mostly responsible for the HAI. Okay, now coming to the first one, that is CAUTI. Okay, তোমাদের next class কি আছে? So catheter associated UTI মানে কি? The patient has to have a catheter and the patient has to have a UTI. Simple. Now the time duration, catheter পড়ার পরে 48 hours পরে the symptoms should occur. First point. Second point, the patient must have any one of the symptoms of CAUTI. শুধু যে একটা ব্যাকটেরিয়া এলো ক্যাথিটার থেকে, ইউরিন থেকে, তাতেই আমরা CAUTI বলে দিলাম, no. If you see the CDC guidelines, they are specifically mentioned that the patient has to have a fever or suprapubic tenderness or abdominal pain or dysuria. Acha. So first thing that you collect the urine, then you put the sample for examination under microscope to see what? Pus cell, which is pertinent to our infection diagnosis. Pus cell যদি low থাকে, 2 to 3 pus cell, and you have a Klebsiella in the growth, how do you define it? Can you call it a CAUTI? That doesn't signify, that doesn't match the infection. That can be a contaminant also. Klebsiella can be a contaminant also. You have contaminated while drawing the urine. That's how it has come. যদি pus cell significant থাকে, infection হলে তো তার বডির একটা reaction থাকবে if the patient is not immunocompromised. Then you have a high pus cell, 10, 15 pus cell, 50 pus cell, plenty pus cell in the urine. Then you have an organism that matches with the systemic manifestation. Then you can call it a UTI. Okay. So ekhaneo dekho, it spreads through two way. One is an extraluminal spread. Lumen is the catheter lumen. One is an intraluminal spread. Extraluminal mane patient's flora, patient asepsis যদি ইনসারশনের টাইমে না মেনটেন করা হয় তাহলে যে অর্গানিজমটা স্প্রেড হবে, যেভাবে স্প্রেড হবে, দ্যাট ইজ কল্ড extraluminal spread. That is most of the cases. And intraluminal spread হচ্ছে যদি তোমার এই ক্যাথেটার সিস্টেমটার ক্লোজড সিস্টেমটা যদি কোনো ব্রিচ হয়, সাপোজ ক্যাথেটার থেকে ইউরোব্যাগ খুলে চেঞ্জ করেছে বাট ক্যাথেটারটা তখন বেডের পাশে লেগে গেছে, মানে এন্ড পোর্টটা, the catheter port is brushing against the bed of the patient, then the bacteria can get inside the catheter and spread and cause an infection. So there is an intraluminal spread. When you are changing the catheter or when you are touching the catheter, if you do not do a hand hygiene before it, you are contaminating the surface of the catheter. That will give rise to an extraluminal spread. That is the commonest one. আচ্ছা, ক্যাথেটারে কি ক্রাইটেরিয়া দেখো? ক্যাথেটার ক্রাইটেরিয়া হচ্ছে আমি বললাম সাইন্স অফ দ্য পেশেন্ট, so there should be a sign of the UTI. Then you have a urine culture criteria. কি বলছে? At least you have to have 10 to the power 5 CFU per ml of organism. That means তোমার যদি আসে 100 organism or 100 CFU per ml or 1000 CFU per ml, then you cannot call it a CAUTI. You have to have a 10 to the power 5 CFU per ml of colony count in the culture result. Then you have prevention bundle. Acha, all the HAIs are controlled or are monitored or are audited by some guidelines, specific guidelines. Is the duty of the nursing staff to fill it up every day. কি কি করতে হবে না, প্রত্যেকটা হসপিটাল অ্যাকোয়ার্ড ইনফেকশনে দুটো করে ক্রাইটেরিয়া থাকবে। একটা হচ্ছে ইনসারশন চেকলিস্ট, তার মানে আমি যখন ডিভাইসটা পড়াচ্ছি, হাউ উইল আই ডু ইট, দেয়ার ইজ স্পেসিফিক চেক পয়েন্টস, ইউ হ্যাভ টু টিক অ্যান্ড ডু ইট। অ্যান্ড দেয়ার ইজ আ মেনটেনেন্স বান্ডেল, দ্যাট ইজ একটা ডিভাইস যখন আছে এভরিডে ইন রাউন্ডস হোয়াট উইল আই সি। So one is the insertion bundle, one is a maintenance bundle. So this is called bundle care approach for the HAI to prevent the infection. So catheter insertion bundle er moddhe see you have appropriate indication. At a patient esche CVA patient, paralytic patient, you want to do a catheter so that the patient is not bedwetting, male patient. Do you do a Foley's catheter straight away? No. যদি না তার কোনো urinary tract abnormality থাকে, if the patient is unable to pass urine, then you do a Foley's catheter. If the patient is able to pass urine, you do not do a Foley's catheter. You do a male cath. Simple. External catheter karo. You don't need to go inside the urethra. No, you do external catheter. That will not give rise to a CAUTI. Then you have a sterile item must be used. Catheter করলাম, ক্যাথেটারটা খুলে দিয়ে টেবিলে রেখে দিলাম, তারপর ওইটাই ঢুকিয়ে দিলাম পেশেন্টের গায়ের মধ্যে, so the patient will have a UTI. Only sterile items should be used. Even if the xylocaine jelly that is used to lubricate the catheter should be also sterile, single use. Then you have closed drainage system. Catheter is attached to urobag. The urobag ta jokhon tumi protidin khali korcho, the urine bag, you should not disconnect the the urobag from the catheter, because that will give rise to a unsterile environment. Intraluminal spread hote pare. Okay. Catheter must be of appropriate size, because if you do a larger caliber catheter to a patient, that will give rise to a mucosa injury in the urethra, that will give rise to infection. And then again properly secure থাকতে হবে। কেন? যখনই ক্যাথেটারটা properly secure না থাকবে, there is a balloon inside the catheter which is inflated so that the catheter doesn't come out. And whenever you are not securing the catheter, there will be a traction, patient টানতে পারে হাত দিয়ে, কিন্তু পেশেন্ট এপাশ ওপাশ ঘুরলো, ক্যাথেটার টান পড়লো, that balloon causes injury in the bladder mucosa and there is a bleeding inside, and whenever there is a blood, there is bacteria, right? So securement of catheter is very, very important. Okay, so this is the insertion bundle. So these are the steps that you should follow during insertion of the catheter. Next, you have a maintenance bundle, that is a daily checkpoint, a daily checklist of what you have to do if the patient is in catheter, bedridden, lying there, and you are a nurse or you are a doctor that is going to see the patient. First thing is daily catheter care. You have to ask the nursing staff or the technologist that have you done a catheter care to the patient. That means whenever the catheter is inserted, see there is a medical device, a foreign device that is inserted into the urethra. There will be organism present in the anterior urethra that will be colonizing the spot. There will be some secretions. That secretions and this colonization will give rise to infection. That will travel extraluminal spread to the bladder. Okay. So, daily catheter care is given by, it can be given by normal saline, it can be given by soap and water. Okay. So, that is recommended for daily catheter care. And then again the catheter has to be secured, and yes, very, very important thing, the urobag must be below the bladder level at all times. Previously I used to see patients, roaming around with a catheter and urobag is here. So, this is the urobag, the patient is roaming around. If you roam around with a urobag like this, the urine is here and your bladder is here. So, the urine from the urobag goes into your bladder. All the E. coli, Klebsiella, Acinetobacter, Pseudomonas go inside your bladder. That is not done. So, the urobag has to be below the bladder level at all the times, no exceptions. Okay, closed drainage system आगे बोलेছি, and yes, hand hygiene, most important. Hand hygiene করতে হবে always. And the assessment to remove the catheter must be documented. Yes, I have seen the patient and I have found that the catheter must be there today. I write it down. I have seen the patient and the catheter can be removed. So, remove the catheter, write it down. In medical science, in your whole life, if you do not write a document, you have not done it. If you see a patient and do not give a round note, you have not seen a patient. In court, you cannot stand. Patient will say that you have come, but you have not written, or the patient will say you have not come, because he may forget. So, you have to write it down. So, readiness for removal of the catheter must be written down on the file. Now, coming to the second thing, that is ventilator associated pneumonia, VAP, very, very important topic, and mostly the morbidity and mortality of the patients in a hospital, in a ICU on ventilator occurs through this, very notorious. Okay. Mortality rate, see, up to 40%, okay, and the incidence rate is 1 to 46 per 1000 mechanical ventilator days. That is very, very high. The second most common nosocomial infection. By the CDC definition, they say that the patient should be on a ventilator for at least 2 days, that is 48 hours, and then you can diagnose a VAP. So, what happens is, whenever you are putting the patient on a ventilator, you do something called endotracheal intubation. So, you put a laryngoscope inside and then you put a ET tube. Okay. So, the ET tube is fixed inside the this thing, and then you connect the ventilator through the tube. Now, see, we all have oral secretions, and the most contaminated part of the whole human body is where the patient is colonized with all the streptococcus and this thing and that thing in the mouth, in the respiratory secretion, and the patient is in a ventilator. The patient cannot speak, the patient cannot cough, the patient cannot say. So, these secretions goes inside this device, it colonizes the device, forms a biofilm or whatever, and then it penetrates and goes down in the lower respiratory tract and give rise to a lung infection, a pneumonia. That is exactly a ventilator associated pneumonia. If it would have been like the patient is not in an endotracheal tube, the patient keshi bar karita. Cough reflex is gone, the patient cannot cough. So, all you have to do is daily you have to put the secretion out of the patient. Joto oral secretion hocche, take it out. Subglottic secretion, take it out. And then you put a good mouth care and a oral hygiene, so that this contaminating organism does not get inside. Tarpore to hand hygiene achi and cross contamination achi. So, this is basically a overview of the VAP. Risk factor bollam, intubation, jeta patient is very, very important. It disrupts the normal ciliary clearance, cough reflex is gone, and damages the respiratory epithelium. So, these are the contributing factors to it. And colonization in the mouth or in the oropharyngeal flora, jeta colonize kore, Haemophilus, Streptococci, Viridans, anaerobes. So, these are the things that colonizes the patient. Okay, so diagnosis, so we have few things, we have some criteria. we have endotracheal aspirate, we have bowel fluid, and we have a protected specimen brush or lung biopsy. See, the diagnosis is huge. It is very difficult to remember the diagnosis, but I'll tell you first few steps. You see this thing? You don't have to remember this. This is for me, okay, not for you. But see the steps, left side, imaging. That means you have to do a X-ray to the patient first to diagnose a pneumonia or a CT scan, okay. So you have to have a new onset or a fresh lesion in the lungs. That is suggestive of a pneumonia, first point. Second point, symptoms. Key symptom thakbe, fever thakbe, okay. The patient will have a respiratory distress. The patient will have excessive secretion, or the consistency of the secretion will be different. Then you have blood parameters, either leukopenia or leukocytosis. CRP will be high, procalcitonin may be high, okay. Then you have PNU1, PNU2, PNU3, that is categorization of the VAP. PNU1 category VAP, PNU2 category VAP, and PNU3 category VAP. PNU3 are mostly immunocompromised patient, so we don't get to see the immunocompromised patient every day. So this is rare. PNU1 and PNU2 is common. Tar moddhe PNU2 ta sobtheke beshi common. Keno? PNU2 can be diagnosed with at least one of the the clinical findings and the microbiological finding. Microbiological finding moddhe ki thakbe na ei je endotracheal aspirate jodi hoy, there will be a growth in the ET aspirate of a colony count of more than 10 to the power 4 for bowel fluid, and endotracheal aspirate 10 to the power 5 thakbe. So if a ET aspirate comes with more than 10 to the power 5 colony of organism, then that is suggestive of a VAP. If a bowel fluid comes with a more than 10 to the power 4 colony of organism, that is suggestive of VAP, like that, okay. So there are few pathogens which are excluded, like coagulase negative staph and others. So that is not considered to be VAP. এর মধ্যে এই যে organism বলছি এত এত colony count থাকবে, the most commonest organism is Acinetobacter, followed by Klebsiella. So this is how actually we diagnose ventilator associated pneumonia. Maintenance bundle এর মধ্যে you have to elevate the patient's bed 30 degree to 45 degree. You have to have a daily oral care with chlorhexidine solution যাতে করে colonization টা কমে. You have to do a peptic ulcer disease prophylaxis, anti-DVT prophylaxis. কেন না patient is bedridden, the patient can have a deep vein thrombosis, okay. Then you have a daily assessment to remove the mechanical ventilator. So I think I'll stop right here because there's no point in progressing further. তোমাদের পরে ক্লাসটা আছে, and there is no point in discussing SSI and CLABSI in 5 minutes, okay. In my next class, if I have time, I'll definitely go for it again. দুটো বাকি থাকলো আমাদের, SSI and central line associated bloodstream infection. You find interesting in reading HAI? ব্যাকটেরিয়া ক্যারেক্টারের থেকে বেশি ইম্পর্টেন্ট মনে হচ্ছে? ওইটা আগে বেসিক বুঝতে হবে, নাহলে SSI করে কি হবে? You have to diagnose, no? See, in your part is that you have to diagnose which is the commonest organism and how to find the organism, so you can give the correct or rather the appropriate antibiotics. Patient তোমার রিপোর্ট এসছে যে occasional gram-negative bacilli seen in the ET tube suction that same day, and you are still continuing teicoplanin, then there is no use of studying microbiology. Teicoplanin is what? It's a gram-positive antibiotic. So this is the basic that you have to learn. So antibiotic stewardship is very important. That is the end point. That is the goal of the whole study. The whole study is how to you diagnose the infection and how will you treat it. So read it, and yes, you read the basic first. If you don't know the TSI, then what is the point of studying Acinetobacter? No? Biochemical testing, characterization of bacteria, these are the things that you should know first. Okay? Thank you so much.